Hello and welcome. My name's Alana Gordon. I am a reporter and producer at The World, covering global health. This is a Facebook Live Q&A about the coronavirus pandemic, what we know, and also what we don't know. With me here is Dr. Caroline Buckee, an associate professor of epidemiology and associate professor of the Center for Communicable Disease Dynamics at the Harvard T.H. Chan School of Public Health. Thank you for joining us.
Thank you for having me.
And you can post your questions for Caroline and me on our Facebook pages at Forum HSPH and at PRI The World. Or you can email them to theforum@hsph.harvard.edu. And this Q&A is jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and The World from PRX and WGBH. We are doing this on Zoom through Facebook, so thank you for your patience. And let's begin. So Caroline, about a month ago, it's hard to believe, the World Health Organization declared COVID-19 a pandemic. And as you are monitoring this and tracking it, where are we right now in this pandemic? If there's a way to even explain that.
Sure. Well, I think that really depends on where you are in the world. So early on, we saw, as the outbreak started in Wuhan, China, we saw areas that had high rates of travel from China see the first of the epidemic. And so cities with high air travel, like Singapore and so on, saw early cases, and they are now into a different stage of the epidemic compared to other places. So there's a lot of heterogeneity, and it really has followed the pattern of international travel sparking the early epidemics, and then the extent of community transmission subsequently varying depending on where you are. And now many countries, including the US and many parts of Europe, are well into their first wave of this pandemic. Countries like Italy and Spain have seen a huge peak of cases and subsequently deaths, whereas in other places the epidemic is just starting to get going. And furthermore, in many areas, we don't really know where we are with the epidemic because of the lack of testing. So I would say it's very variable geographically and in terms of timing.
What areas are you not sure about?
Well, I think there's been slow testing capacity ramp up in many places, including the US. So I think we still don't really know where we are with this epidemic in many parts of this country and elsewhere. So for example, in places like sub-Saharan Africa, where we're just starting to have testing come online and see cases and deaths, it's hard to know really how far we are in the epidemic in the absence of testing. So I think there's a lot of uncertainty still in terms of how many cases there really are. And there's a lot of people that aren't getting tested. And so that makes it very uncertain in terms of understanding where we are in this wave, where the peak will be, and what we should expect in the future.
One of the things I wanted to ask, what are some alternate ways to testing that you can track this?
So I think that there are a number of ways. It's important to make a distinction between virological testing, which is what most people think of when you talk about testing, which is diagnostic testing for the presence of the virus itself. So at the moment, we have a PCR test that uses the RNA from the virus to tell whether you're infected or not. But there's also serological testing, and serological tests look for an antibody response, the body's immune response that is specific for the virus. And that's an indication that you have been infected in the past and you now have developed an immune response to the virus. We don't know whether that immune response is going to be protective against reinfection, but it's at least going to tell us things like how many people had mild cases, how many people had no symptoms at all. So what the overall size of the epidemic has been so far, and what we might expect into the future. There's a third kind of surveillance that in many settings is more practical, and that's syndromic surveillance. That means you're looking just at patterns of symptoms that are consistent with COVID-19. And so a lot of different mobile apps and other kinds of surveillance systems can pick up patterns of fever that look anomalous. So they look like they're higher than you would expect normally. And we can also use those kinds of, that kind of information to inform what's going on with the epidemiology.
You wrote an article in The Lancet, Digital Health, about how researchers can use big data to track and respond to epidemics. And I imagine that's a little bit different but connected to what you're talking about. And I wonder if you could expand on that.
Yeah, I was talking about a specific application of aggregated data from mobile phones and other mobile devices. And in that case, epidemiologists and others have been using aggregated data to understand the mobility patterns of populations in relation to epidemics for forecasting purposes and making sense of how fast diseases will spread. In the context of this pandemic, that kind of information is coming to the fore as a really critical piece of monitoring social distancing, which we should call physical distancing, in fact. So you can use aggregate data to look at mobility patterns which respond to particular physical distancing interventions, trying to monitor how well they're working, whether they're working differently in different places, and then to monitor travel in order to make estimates about how and where the disease will spread next. So that's what that article was mainly focused on, although there's a whole lot of other technological approaches to this pandemic, including, of course, the contact tracing apps people are developing, as well as telemedicine and other kinds of approaches for syndromic surveillance that involve engaging with people through their mobile devices.
And are you utilizing any particular network or data for you in particular as you track this?
Yeah, so building on the work that we've been doing in my group for several years and the research community that is involved with this kind of modeling, we've been developing a network of researchers who can use this kind of data from apps and mobile devices, things like Facebook data and other things, to monitor mobility patterns and aggregate them in a way that's safe and protects individual privacy in order to help policymakers and decision makers kind of make sense of what's happening. And I think that the crucial piece is that because we've been using this kind of data for a long time, we understand the inherent biases and uncertainties associated with this kind of data. We've worked out protocols to protect individual privacy, and we're very careful to make sure that the interpretation fits the constraints of what the data can tell us. So we are working very hard to try to support decision makers while making sure that we're providing rigorous and safe estimates.
So based on that and other things, what is it telling you? And is it telling you anything about whether social distancing efforts are working, as one example?
Yeah, so I think this kind of aggregated mobility data is one of the only ways that we can start quantifying the impacts of physical distancing interventions. As it is, when you implement a policy like school closures or working from home or closing restaurants and bars, it's not really clear what that means for the contact rates. So when you see epidemiological models in the literature and in the press, all of those rest on the assumption that contact rates are what we are impacting with these physical distancing interventions. So that's the rate at which people are coming into contact with each other. So we think that that's impacting the spread of COVID-19 around communities, but it's really hard to measure that and monitor it. And in the absence of good data, it's going to be really hard to make evidence-based decisions about how to relax physical distancing interventions as we try and open up the economy again. So this type of mobility data can give you a proxy for the contact rate that is leading to the transmission of the virus. And so if we can start making statistical relationships between the amount of reduction in mobility that we see and the subsequent impact on COVID-related morbidity and mortality, then we can start to build evidence-based policy as we start to think through the relaxation of interventions on the other side of this outbreak.
So just to make sure we're understanding this, it sounds like it's a really powerful framework, but what is it that you're still needing to really help that inform decisions?
Yeah. So at the moment, one of the critical missing pieces, and you will have seen that there's huge uncertainty around the models and the forecasts and what they're telling us. And the reason that that's so uncertain is because we still don't know how many cases there are in any particular location. And that's because testing capacity is very constrained, but also because we're missing mild cases, and we don't know how many people have no symptoms at all, and they never develop disease. So without understanding more about the basic epidemiological parameters of this virus, we really have a huge amount of uncertainty about how many cases there are. So that makes it very difficult to make sensible estimations about how well social distancing is working. And in fact, I think at the moment for the US, for example, some of the only robust data that we have on what's going on is through COVID-19 deaths, unfortunately. And because there's quite a long time lag between the infection and the death, it means that, and of course, death is just a small fraction of people that have the disease. It means that until we have a sufficient signal in the trajectory of deaths, it's quite hard to extrapolate that out to what's happening with incidence of the infection in the community. So we're still relatively early on in this epidemic, and we don't understand a lot of the parameters. So making decisive or making definitive statements about whether social distancing is working, short of saying that it does seem to be having some impact, but right now we're not able to really quantify exactly the relationship between the social distancing interventions that we've put in place and subsequent transmission. But we're working on that, and as more data becomes available, we should be able to parameterize those models in a more certain way.
So I want to move to some of the questions, and you've touched on this, but we've had several viewer questions come in. This is something you referenced in the beginning about we're in this first wave. And so this question from Lindsay is, if we lack herd immunity right now, meaning how many people are exposed to then prevent the continued transmission, if we lack a vaccine or universal testing to identify carriers, why won't we just have another major wave, a second wave of infections, if we halt or when we halt social distancing, which is what's being proposed by a lot of government leaders. And Lindsay brings up that in the 1918 flu period, the big flu pandemic, there were 3 waves. So will we see this with this virus?
Yeah, I think this is a huge question, and it's something that epidemiologists are very worried about. There's a difference. You may have seen a lot of these epidemic curves in the literature. So there are different ways that you can achieve a curve that goes down. And one of the ways is that you run out of susceptible people through herd immunity. So enough people have had the disease that, like a forest fire that's run out of trees, the disease just can't spread anymore because there's not enough susceptible people. When we're seeing the curve flatten and turn down in this case, it's not through that mechanism. It's because we've done sufficient physical distancing that we've sort of artificially reduced the contact rate such that the disease has started to go away. So once we reverse that, we are at risk of major resurgence. And in fact, Singapore is now seeing some resurgence following the relaxation of physical distancing interventions there. And China is having to manage their own uptick in cases following relaxation after their first wave. So that's a very important consideration for us. And of course, a second wave in the fall and winter months, when we have other circulating respiratory viruses and conditions that are conducive to transmission, that's a very big concern. So yeah, she's right that there's no reason to think that if we relax social distancing, the disease will have gone away. That's absolutely not the case. We're going to have to come up with strategic, staged relaxation of physical distancing in a way that protects vulnerable people for as long as possible so that we can manage this from the health system side, at least in the US and Europe.
This kind of feeds into an online question about then what then does this mean if we're seeing these second outbreaks or predicting them for ultimately being able to reopen society? And I guess what you're saying is kind of this staged reopening or reentering.
Yeah, I don't think that there's an easy answer to this, and I don't think that there's a very clear path. We have to weigh the risks and benefits of continuing to do strong physical distancing interventions versus opening up some sectors and risk some resurgence. And I think there isn't an easy answer, but it's clear that we need to do. The first thing is serological testing, right? So first we need to establish We need to learn more about immunity and whether people with antibodies are actually protected. We still don't really know that, although based on what we know from other seasonal coronaviruses, we think that there probably is some protection after infection. So we need to learn more about immunity, and then we need to go and do serological testing. And so you could imagine a scenario whereby people who have had the disease and have tested positive for antibodies are able to go back to work, or low-risk groups, so sectors of industry or particular households with low-risk groups may be able to go back before high-risk individuals or high-risk locations. At the moment, I think all of those strategies are still being debated, and it's not clear what the right one will be. Certainly, we're going to have to be adaptable and be able to hopefully kind of tune and ramp up and down some of these physical distancing interventions, because otherwise we risk an enormous resurgence when we do reopen.
I have a question bookmarked from a viewer about the distancing, but when it comes to the tests, a question online is, just backing up a moment, what hope do you have for the availability then and accuracy of an antibody test?
So I think there are a large number of different tests that have been developed quite rapidly that show promise. And I think that we will definitely be scaling those as quickly as possible. And I have hope that we will be able to start doing seroprevalence survey. So that's looking at what fraction of people have antibodies very, very soon. And that's going to be an extremely useful tool as we start to make sense of not only who's protected and who can go back to work, but also it will give us a much more definitive answer on where we are in the epidemic and which communities are now close to being able to open up some aspects of the economy.
Here's a question from Louise. If a person was exposed and asymptomatic, and let's say when we're thinking about future antibody tests and immunity, does that affect their future immunity? Do we know that yet compared to someone who was sick? And does that better predict future immunity? Yeah.
So we still don't know the relationship between antibody titer, or how many antibodies you have, and your level of protection. There was a recent study, it hasn't been peer reviewed, but there was a recent study that showed that among people with mild symptoms, a large fraction of them did have antibodies, but some fraction had much lower or even undetectable antibody response. Now, the relationship between those measurements and whether people are actually able to be reinfected is something that we still don't understand. I think that based on what we know about other coronaviruses, many epidemiologists are cautiously hopeful that we'll have at least some period of protection among most people that get this disease. And, in other situations, more antibody is better. So we're still guessing, and we need to collect more data. But it seems as if the amount of immune protection you get may or may not relate to the symptoms you've had. We still don't know that.
Okay. So I have a question from going back to the notion of social distancing, and kind of as you're trying to figure these things out, and as we think about, and governments and policies think about kind of staged re-entering of things. This question comes from Dick Knox. In an online chat yesterday with Helen Branswell of STAT, Dr. Tom Frieden, former CDC director, said that all elders and also younger people with disease risk factors like chronic diseases will need to continue isolating and distancing after others start to go back to work and school. And that these kind of prolonged precautions for the elderly, as an example, could go on for a while. I know that you mentioned that it's too soon to really know what's the best way and we have to figure this out, but based on what you do know, what are your thoughts on this and your rationale of whether that's a way to go?
Yeah, so I think that there are sort of two axes of vulnerability when we think about relaxation of physical distancing and how we want to move forward. So there are going to be, if we think about a population and we think about who's vulnerable to having to be hospitalized and possibly die, right? Because in many ways, that's what we're thinking about when we talk about surge or being overwhelmed. We're talking about the capacity to deal with hospitalized patients and an overall mortality. So given that there is a very strong relationship between age and the probability of hospitalization and death, and of course, it's not just age, it's linked to frailty and other underlying conditions, but age is a very strong signal. Given that, I think when we are thinking about relaxation of physical distancing, we do want to really make sure that we are doing it in a way that protects vulnerable groups for as long as possible. So demographically, that does mean elderly people. There's also a geographic component to how we relax physical distancing, right, in different communities over time. And, you know, more remote communities, for example, may end up not having had the epidemic and therefore remaining quite vulnerable to it in the aftermath. So I think there are kind of geographic aspects of this kind of staged relaxation, as well as demographic aspects. And I think it's certainly the case that we want to keep in mind the protection of vulnerable people who would be the bulk of, you know, ICU admissions and hospitalizations and deaths if we do have a resurgence.
So this question comes from, I want to keep on this thread for a little bit, but there's a lot of other questions coming in about the disease itself and a lot. So as far as this question comes from Alex, I'm a student at a college, and my question is then what needs to happen before students can safely return to colleges? And will this happen by the fall semester?
Well, obviously I can't say definitively if it will happen. I think our students and our college students, first of all, they are low risk in terms of their age group, with the caveat being that some underlying morbidities are going to be problematic. The real issue here is the extent to which particular age groups contribute to transmission overall. And the way that epidemiologists think about that is using the idea of age-structured contact matrices, which is a little technical, but basically we want to know how do different age groups interact. So when you think about your close contacts, what are the age of your close contacts? Generally speaking, in populations, people tend to have most contact with people their own age group. And then, of course, within households, you know, parents of small children have contacts with younger age groups. But broadly speaking, in the population, most people are contacting people around their own age. That will vary by context, by country, depending on the household structure and all kinds of other things. So the answer to the question really depends on what you believe about the patterns of mixing and how you think restarting colleges might impact some of these vulnerable populations that we were talking about in the previous question, right? So it will sort of depend on the setting, but in places where college students are somewhat restricted in terms of their contacts with other vulnerable populations, then I think it would be not unreasonable to think about them at least in the first stage of relaxation of these policies. But again, it's really context specific. If you have a lot of college students that live with elderly parents, then that could be dangerous. So I think that we really have to understand the structure of these contact patterns in different places and try to make as informed a decision about that as possible.
This question comes from Togchi. The question is regarding modeling the spread of COVID-19 in countries where testing is very limited. I mean, but specifically about countries that are also in communities that are economically constrained and may be forced to open up soon. So what's the best approach to estimate the spread of diseases and timelines for opening places up in these types of communities?
Well, without a specific country in mind, there's such a huge heterogeneity in terms of the health system capacity to manage patients. If in a very resource constrained setting, like say a refugee camp, where there is no ICU bed, there are no ventilators, there are very few medically trained staff, you have to think about your response in a way that reflects that setting. So for these PCR tests that we're relying on, those require lab facilities and so on. However, almost all countries have a pretty well-established influenza-like illness surveillance system. So to some extent, there could be, adapting current systems that already exist to try to understand what's going on with this. Again, syndromic surveillance, where you just try and look at patterns of fever that look anomalous, could be helpful. Again, there's a question of what you do in response to that is going to be important. But I think in resource-constrained settings where they're trying to balance the response to COVID with all of their other health system needs, right? So one of the premises of this flattening the curve idea is that we bring the hospitalizations and deaths below some threshold where the health system can manage. But if your health system is already overwhelmed and you are very reliant on, aid pipelines and routine childcare immunization programs and these kinds of things, then disrupting the system and preventing people from being able to access normal healthcare and livelihoods may not be worth the benefit of trying to slow down COVID-19. So I think that each place has to really think about what they can do, what's going to be feasible, and then weigh that against the other competing priorities that are really important for people's livelihoods and therefore health and life as well as the risks of other kinds of deadly diseases. So, for example, if you disrupt measles vaccination programs, then children will die of measles, no question. And so, there's very complex decision making that has to go into that question, I think. It's not easy, but I think the bottom line is that all of these interventions should be context specific. We shouldn't assume that we can just take a set of interventions that works in a high income setting and just move it to a low or middle income country. That's not necessarily going to work. It has to be very much local.
Yes, but we are getting a few questions that have to do with this one from Rick, and then I want to read one from Lawson. And I say yes, but because the questions coming in are, but what can we learn from the different ways that Taiwan, Singapore, South Korea have approached coronavirus, and what might also be the biggest takeaway lessons from countries that were previously hit by SARS, which were part of this kind of first wave. Can you learn things from?
So yes, absolutely. But again, Singapore and South Korea have incredibly high functioning health systems and capacity. So the previous response was thinking about really highly resource constrained settings. South Korea and Singapore are not resource constrained, and they did an amazing job at suppressing the initial wave of COVID. South Korea, for example, they rolled out incredibly rapid, widespread testing across the board. They had social distancing interventions, not as strict as in China, but significant, as well as aggressive case finding and contact tracing and all of that. So a sort of combined effort of multiple interventions coupled with aggressive testing and testing widely, not just people that are coming into hospital, but much more broadly in the community, really was the way that South Korea did a good job of controlling transmission there, and similarly in Singapore. So I think we can learn from them, but again, those are specific settings, and those approaches are going to work well in some places and not so well in others.
So we don't have too much time left, but we've also been getting questions that have more to do with the virus itself, both clinically and also virologically. So this question from Ellen is there any information about different strain variations and also the clinical implications of that?
So there's always a question during an emerging outbreak like this of whether the virus is evolving to be more deadly or less deadly. So what I would say is that, all viruses mutate. And from what we know from the genomic data so far, so looking at the genome sequences of these viruses, this virus is mutating in a kind of standard way relative to other similar viruses. And we don't see any evidence yet that there is systematic evolution to being more or less deadly. There's no evidence for that. Similarly, there's not really any kind of different strains at the moment. We have a phylogenetic tree that you may have seen online, and those trees just are a reflection of the spread and mutation in a virus. It doesn't seem to be behaving in a way that suggests that there are multiple strains per se. That's an arbitrary designation. And there's no evidence so far that it's evolving in a way that makes it more deadly or less deadly. So there's no evidence for that so far.
And then here's a question from Tom Howell. What do we know about patients who've recovered in terms of lingering problems? Are there any particular kind of health challenges they're reporting after being cleared of the virus? Might these persist?
I don't know is the short answer. I haven't looked at that data, so I'm afraid I can't say.
Sure. Another thing that has come up a few times is how safe are food delivery services? Can that be transmitted? Can COVID be transmitted through that?
I would direct people to a very good article that Joe Allen at HSPH wrote about this. Essentially, we think that the main mode of transmission is droplet and, from person to person through coughing and so on. Fomites, which is, viral particles on surfaces and things, may play a role, but we don't know yet. But I think it's relatively safe. The advice that you should always wash your hands before you sit down to eat something is a good piece of advice in general. And take care, of course, and rinse things and so on. But I think I don't think people should be too alarmed about eating delivery or things like that.
Helpful. I guess just to wrap up, I'm always really curious, especially people like you who work in epidemiology and your whole kind of focus is trying to track the spread and course of the virus. And I wonder with this, if there's something that's really surprised you about coronavirus, even like within the last week or so, because it seems like so much is changing so fast as we learn more, and yet we don't know things, but we're making assumptions. And the predictions are important, as Mike Ryan says at the WHO, but to not put too much weight into those as truths. So I wanted to just hear kind of what you're humbled by, but also maybe what has changed for you.
I think the big question for me from the beginning, and it remains the big question, is this issue of asymptomatic people. So what fraction of people have no symptoms at all for the entire duration of their infection? And are they spreading it to others? This is still an unknown, but in the last kind of week, we've started to see really variable reports where, there was a recent study in pregnant women in New York that showed that quite a high fraction of them had no symptoms and they were virus positive. So of course, that's a particular cohort of people with particular characteristics, but still it implies that there's quite a lot of asymptomatic carriage. Meanwhile, in other studies, there seems to be much lower prevalence of asymptomatics. And the reason that this is so critical right now is because if there is a lot of asymptomatic carriage, it means we're much further along than we thought. And that's good news in general. So I remain very curious about these seroprevalence surveys and what we can learn about the fraction of people who have already been infected, what that can tell us about how far along we are and when we can start, trying to go back to work and restart economies, and what that means for low income settings too. So for me, that's the piece that I'm really keeping track of the most right now.
Yeah, I think that it must be such a difficult place because as policymakers are trying to figure out what next and what to do in this moment, this information is so critical, and yet we're not quite there yet, it sounds like.
Yeah, but I think, one thing to say, you said at the beginning that it's only been a month. The pace of science is just astonishing. It's really unprecedented. And I think the other thing that's been like somewhat heartwarming is just the networks of researchers that have come together to fight this thing, and, you know, from across, you know, internationally. And that's been really remarkable to see the sort of collaborative spirit to try to do something useful. So I guess that's one silver lining.
Well, I guess we can end on that silver lining. Thank you so much. This concludes our Facebook discussion. Caroline, again, thank you for fielding everyone's questions.
Thanks for having me.
Yeah. So this Q&A has been jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and the World at PRX and WGBH. And you can view this full discussion on our Facebook pages and also send feedback at Forum HSPH and at PRI The World. You can join us again this Thursday at noon when we'll be talking with Dr. Paul Bittinger about hospital response during the peak of the crisis. So thanks again, and let's keep the conversation going.